Now we're going to a little bit talk about the private insurance market. Now we're going to distinguish the private insurance market later by talking about the public insurance market, just to orient you to some of the differences. So there are many different types of private insurance that you should be familiar with. The first one we're going to talk about is individual private health insurance non-group. This is the kind of insurance that you can go out and buy either directly from a health insurance agent or through an health insurance exchange. Your premiums in many cases used to be based on your individual health and demographics. So this was back in the pre-ACA period. This is where you had to go in and fill out a health questionnaire, and based on your age and based on your risky behaviors or non-risky behaviors, your current health to date, your premium would be set. So people who did not have access to group or employer-based insurance faced significant variations in premiums based on their behavior, based on their demographic group. This was the group that most regularly had difficulty accessing health insurance that they could afford. Now, many people who had access to health insurance and access to health care through non-group policies saw their policies be eliminated because of the Affordable Care Act's new provisions and requirements for health insurance plans. Health insurance plans now sold in the United States cannot base eligibility and premiums based off of individual health and demographics. They cannot include pre-existing condition limitations. So many people in the United States who had been purchasing non-group private health insurance saw those plans get canceled. You may remember that President Obama got in a lot of trouble for this when he made the promise that no one who currently has health insurance today will ever lose their coverage. Well, that turned out not to be true because many people in the non-group insurance market saw their plans get canceled in 2013. And so as a result, those people had to go and buy health insurance through the health insurance exchange, buy a new policy that complied with the new law of the land. That was something that many Republicans seized on and said, we told you people were going to lose health insurance under the Affordable Care Act. We told you that this was going to hurt people in America. But of course, the truth was that those plans were being canceled because those plans actually were really very harmful and very discriminatory for many Americans. They were not having their premiums based on the community health rating. They had their premiums based on experience ratings, which made them pay much, much higher premiums than others. And so while it was true that people's policies got canceled, they were then eligible to buy new policies that were likely to benefit them from the health insurance exchanges. There are also things called managed care plans. Managed care plans mean that you have to participate within a network that allows for you to have a primary care provider who will manage your care, who will only with permission give you access to certain kinds of referred services, to specialty care. This kind of care incentivizes you to participate and use physicians within a specific network. That network of approved physicians all practice and all bill according to the conditions that the health insurance company sets. Most plans that we participate in now include some part of a managed care philosophy. There usually is an in-network set of providers and an out-of-network set of providers. Some may also include the primary care provider gatekeeping function. Typically those are HMO managed care plans, but there are also now other kinds of managed care plans that don't include the gatekeeping function, but they're still the in and out of network coverage. Usually we see these are PPOs or EPOs. So it's very important to know that almost all health insurance plans now have some managed care component. Now, group insurance, as contrasted with the individual private non-group insurance. Group insurance is in large part employer-based insurance. And what it means is that employers purchase health insurance not for individuals based on their own individual health behavior, but they purchase insurance for the group. And the entire group pays the same premium and has the same level of benefit as everybody else in the organization. And so it is a comprehensive health insurance package that is available for everyone who chooses to participate in that group insurance. The reason why employers like to offer these plans is that they get a tax benefit for paying for a certain portion of the premium. They get to write that expense off and when they do their individual tax returns as companies. So there's a significant incentive for employers to offer group insurance to their employees. Obviously, employees like this scenario because a significant portion of their premiums are covered by their employer. They only have to pay a small amount of the premium in order to have access to those group health insurance benefits. There also is something called self-insurance. Self-insurance is where employers pay for all the health expenditures of their employees, not as part of a plan, not as part of a third-party group insurance scenario, but where they just pay for those expenditures for their employees directly. Some self-insured companies have been exempt from some of the ACA requirements because they've been grandfathered into the system. But for many companies, this was something that was a solution to the fact that many third-party payers charge high administrative costs, and it is cheaper for companies to simply just pay directly for the health benefits for the services that their employees use. Many different types of health insurance also include what we call sort of these high deductible plans and or health savings options. So what we see is that there are two different kinds of high deductible health plans exist. In almost all instances, what we see is that employers are now offering what we call these health savings accounts, or HSAs, where there is an optional employer contribution to a medical savings account, and where people participate in a high deductible health plan with that medical savings account. The reason why people do this is every month they can put a certain amount of money aside that they save in a health savings account that they can use for a wide range of health expenditures, including things like co-pays and co-insurance or health-related expenditures that aren't covered by insurance. That money is then put into that savings account pre-tax. So you're putting more money, because it's not being taxed and then being saved, away into those accounts. Those savings accounts are usually accompanied by a high deductible health plan, where then you can use those health savings account funds that you've set aside to pay off your deductible. This is something that's very attractive for employers because the monthly cost for the premiums are much, much lower because you're deferring that cost until later on. So this is that distinction that's been made in the videos from Healthcare Triage that says either you pay up front a lot and you pay a little on the back end, or you pay very little up front and you pay a lot on the other side. So this high deductible plan with HSA scenario is one where you're paying a very, very small monthly premium up front. But when you actually have your health expenditures, if you're going to have those health expenditures, you're going to be responsible for those initial $3,000 to $4,000 of expense. The reason why a health savings account is advantageous for many people is if you've been saving this money as you go along, you can use your HSA money to pay off that deductible. If you're not expecting to have a lot of health expenditure during the year, paying this very small premium is likely to benefit you because you may never actually reach your deductible. And so any expenses you have can simply just be paid from your HSA. We also see that there are, in the private health insurance market, policies that we call Medigap policies or supplemental Medicare insurance policies. These cover the out-of-pocket costs that were originally put into the Medicare program. Originally, the only things that were being covered by the Medicare program were inpatient hospital stays. So these supplemental insurance policies that are sold in the private health insurance market are designed to help defray some of those costs that are coming for those outpatient visits and other things that you're incurring in your Part B and Part C expenditures. However, it's not eligible to those people who actually are able to be covered by the Medicare Advantage program Part C. So what we see is that there's a need in the Medicare population to cover some out-of-pocket costs, and that's where those Medigap policies come in. So, of course, when we talk about the private health insurance market, one of the most important things is, of course, to recognize that there are many, many millions of people who, of course, who are uninsured, who do not have access to private health insurance. Well, the impact of the Affordable Care Act is obvious here on this graph. We now have only 10.7% of the population that is now uninsured, down from a high in 2010 of 18.2% of the population insured. Many of these people who are now insured are insured thanks to a spike in private insurance, people buying private health insurance policies through the exchanges. We also see that there's been an increase in public insurance, which we're going to talk about in one of the next upcoming videos. Ultimately, the portion of people uninsured is going down significantly, and that is a result to a pretty significant spike in private insurance through the exchange and a more gradual increase in the coverage of public insurance thanks to expansion of the Medicaid programs. So here are some of the major issues we see in the private insurance market. First, of course, is the fact that we have so many people who are uninsured. The proposed solution of this, of course, was the passage of the Affordable Care Act, and so far we're seeing that that has in fact been a pretty effective solution for reducing the number of uninsured in the United States. Another major issue is not just paying for health insurance, but actually health insurance companies want to be sure that they're paying for quality care, that they're paying for things that are going to result in good outcomes. So one of the big buzzwords now in health insurance is sort of paying for performance, paying health insurance companies paying healthcare organizations for providing high quality and resulting in better outcomes. That's one of the key things we see now as a major trend in the private health insurance market. What we also see is concerns about adverse selection, or people clumping together, that the only people that are likely to sign up for health insurance now are those who are the sickest. Those people are adversely selecting, which the concern is that's going to then ultimately drive up health insurance premiums, because the new people who have joined, those people increasing the upper level of that chart and making that line go up, when health insurance companies start having to pay for all the care that they need, these very sick people who were previously excluded because they had pre-existing conditions or the premiums were too high, what we see is this sort of clumping in these various community risk pools. What is likely to happen is that the premiums that health insurance companies need to charge in order to cover that medical risk is going to be very high. How we're going to deal with that, how we're going to avoid the death spiral, at this point, there's no real solution on the horizon. So this is another one to be continued. Risk selection, cherry picking. What we used to see in the health insurance market is that only the very healthiest would be offered sort of attractive rates in order to participate. The proposed solution is in the Medicare and Medicaid population is to expand the Medicare and Medicaid population. The Medicare Modernization Act of 2003 no longer allows for certain kinds of cherry picking in the private insurance market for Medicaid policies. And so it means that all people are eligible to be covered, not just the very healthiest. And so that's been a solution for dealing with the fact that health insurance companies used to be able to deny policies to people that they didn't want to cover because they thought they'd be likely to result in a significant amount of medical loss. What we also see, of course, and we've been talking a lot about this so far in these lectures, is cost shifting, trying to push the costs off to consumers. We also see cost shifting happening in the private insurance market pushing the cost off to healthcare organizations, to providers, so that now the health insurance companies are not holding all of that risk, that in fact they're pushing much of that risk and much of that cost to the healthcare organization. They're doing that by using something called capitation, which basically says we will pay you for the number of patients that you have on your rolls, the number of patients who participate from your practice, from our plan. We'll pay you a monthly fee for having those people on your rolls. What you do and what you spend and how you use that money, that's your problem. That's your business. We also see cost shifting happening on the part of health insurance companies. What we see is prospective reimbursement. This we've been talking some already in this class about, where basically we say, okay, there's a patient covered on this health insurance plan. The healthcare organization is telling us that they need a hip replacement. Here is your prospective reimbursement. We will pay you X amount for this single procedure. If you spend it all, congratulations. If you don't spend it all, you get to keep that as profit. We are going to simply prospectively reimburse you. You're not going to get to charge us for every single expense, every piece of tubing, every procedure that is done in the course of caring for that person's hip replacement. You're simply just going to get one pile of money, and you do with that money what you will. If you're particularly efficient, you get to keep that money as a bonus. So that's where we see the cost shifting to being the responsibility of the providers and healthcare organizations. So we have cost sharing on the part of consumers from the health insurance industry. We also have cost shifting happening. Both cases, the health insurance industry is trying to push and to motivate the parties on either side of them to push down and control healthcare costs and to reduce the amount of spending overall. So really, health insurance here is the driver of all of these changes that are happening in healthcare financing. Now, some of them, of course, have been motivated by the public sector, by Center for Medicaid and Medicare Services changing this, and changes in the Affordable Care Act. But the real driver, the real actor that has been forced to change healthcare financing is the health insurance industry, primarily the private health insurance industry. We also see major issues related to fraud and abuse. And so this is something where health insurance companies are really having the pressure put on them to ensure that the charges and the billing that they are engaged in are actually accurate. And so having much better oversight of the charges that are happening on private health insurance companies as creating an incentive to reduce fraud and abuse. Now, when we think about cost sharing, not cost shifting, cost sharing, if we go back to that concept for a minute, what we see is that, in fact, what employers have been doing to deal with the fact that premiums have been consistently rising. It's not just about cost sharing on the part of co-pays and deductibles and that sort of thing. What we see is that, in fact, employers are increasingly sharing the cost with their employees. And so in the last 10 years, from 1999 to 2009, what we saw was the amount of the percentage of health insurance premiums that workers with family coverage were being asked to pay increased 128%. So now the average worker with family coverage is paying in premium $3,515 a year. It's even higher now. But for the purposes of this example, what you see is that we have the cost sharing happening not just on the part of the employee or the consumer having some skin in the game with their provider and with their health insurance company. We also see that employers are increasingly asking their workers to have more skin in the game. And this is in part, again, a way of encouraging employers to get their employees to be more responsible, more accountable for the cost of their health care. We also see some emerging trends in employment-based health insurance as we think about the role of employers in providing private health insurance in the market. In 2005, we saw that 91% of private health insurance was employment-based. That figure dropped to 89% in 2011. It's dropped even lower now, and the projections are that in 2019, that actually only about 70% of private health insurance will be employer-based. And part of the reason for that is that increasingly employers are going, and employees are going to see that they may be more beneficial using the health insurance exchanges and buying private insurance, not through groups, but through the health insurance exchanges. And so you see this also in the textbook. They show this trend taking place. What we also see is that, of course, small businesses, because of the increase in health insurance premiums, are increasingly not going to be able to offer health insurance to their employees. Luckily, those employees of small businesses that are not required to provide health insurance to their employees have an option to buy health insurance through the exchanges. We also see, as that previous chart showed, that employers are going to subsidize less and less of the premiums for their employees, because this is such a huge portion of companies' budgets now, because health insurance premiums have been increasing so much. So their employers are going to increasingly ask employees to pay part of that cost. We're also, of course, going to see in employer-based health insurance higher out-of-pocket costs as a result of the cost sharing that companies are seeing in their third-party administrative plans. So here is a set of numbers that show how the economic downturn from 2009 and through 2010 really affected what employers were able to do in terms of offering health benefits. What we saw during this period of time was that companies were very likely to reduce the scope of benefits that they offered. Perhaps they no longer provided vision or dental, perhaps they no longer provided dental insurance, or they increased the amount of cost sharing. About 30% of companies, but particularly large companies, engaged in this additional level of cost sharing. What we saw specifically was that they were most likely to increase the worker share of the premium. So as premiums continued to increase and as the economy got worse, one of the things that employers began to ask was for increased cost sharing, and that trend has continued now today, even as the economy has improved. Now, another term you need to know about in private health insurance is COBRA. COBRA is a program that allows for your employer-based coverage to continue if you've been released non-voluntarily from your job. So if you have been laid off, or if you have been fired not for cause, but you had to be let go, for example, as a result of economic downturn or because of a change in employment. What you see is that you have employees are eligible for COBRA for a limited period of time. There's 29 months of coverage that are eligible for people that are determined to be disabled, and there's a year of 36 months of coverage if someone, a family member dies or enrolls in Medicare or gets divorced. So COBRA is available to deal with those gaps that happen when people change employment, or perhaps change employers from an employer that provided health insurance to an employer that did not. What happens in COBRA is, of course, there's no longer employer subsidied premiums because you no longer work for that company. So you have to pay, you can have the same plan, the same policy, the same level of benefit, but the individual has to pay 102% of the group level premium. 102%, that 2% goes to cover administrative costs, so basically you're paying the entire cost of that premium. The Affordable Care Act did not change in any way the COBRA system, but in many cases, if you're going to be asked to pay 102% of the group premium, you might actually be able to get comparable coverage through a health insurance exchange. So whether or not COBRA will continue to be something that people take advantage of remains to be seen, but it is still an option for people who change jobs and no longer have health insurance benefits. So other trends that we see in the private health insurance market. Of course, we saw the number of people in that chart that we showed you a few minutes ago increasing dramatically to the height in 2009, 2010, 18% of Americans did not have health insurance. Now those numbers are going down. But what we do see is even though there are tax credits and benefits for employers, particularly small employers, to offer health insurance because of the Affordable Care Act, many small businesses are no longer offering that because they know that their employees have an option to buy insurance through the exchanges. We've seen, of course, premiums dramatically increasing from 2008 to 2013 and even beyond. We expect to see significant increases. What the hope is that over time, these double-digit annual premium increases that have been happening will be slowed. And in fact, there were restrictions put on the amount of premium increase that plans sold through the exchanges could actually use. So there are some stopgaps put in place so that we don't continue to see these radical 20% increases year over year. However, many of those restrictions, many of those requirements on the part of private insurance plans have a sunset date, after which health insurance companies will be able to increase premiums without those limitations unless Congress renews them. So right now, at least, there are caps on how much premiums can increase year to year. So whether or not that will continue remains to be seen. The deductible increase from 2008 to 2013 was almost double. So we also see a significant amount, again, in the cost sharing asked of consumers in the private insurance market. What we also see happening as a result of the Affordable Care Act is that many employment-based plans are going to no longer have their grandfathered status. This is the debate that's been happening related to so-called Cadillac plans. There are many plans that are very comprehensive, have very little cost sharing, and therefore people don't have much skin in the game. The Affordable Care Act actually said that those plans also need to go away, but there was a provision put in that said for large employers that had these Cadillac plans, they could continue to offer them for a limited period of time while they tried to transition people off of those plans. What will happen very soon is that employers that continue to offer those Cadillac plans, these very comprehensive, very low cost sharing plans, will actually have to pay a tax or a penalty for continuing to offer these so-called Cadillac plans. And when that happens, what we expect is that most employers will simply pass that tax or that expense on to the consumers who continue to have them, and the belief that those consumers who still have those Cadillac plans will be incentivized to basically drop them, and then employers will no longer have those penalties or fees. There are also going to be new fees put on insurers. So people operating in the self-insurance market, operating outside the normal health insurance required laws, will see that there's going to be a fee imposed on their plans that they operate themselves. There's going to be additional fees imposed on plans sold through the exchanges to help cover these increasing administrative costs. What we expect that all of those fees that put on the part of self-insured or third-party plans are going to just be passed on to consumers in the form of higher premiums. So ultimately, companies and the health insurance companies, employers and their health insurance companies aren't going to feel that pinch. It's going to be passed on to consumers.